Saved me a lot of money.
I'm sure, yeah.
Actually, my husband inappropriately jokes that it's when I go for my hair appointment, it's a mortgage payment. So
So congratulations both, Michelle and Eric, for the doctor.
Thank you.
Wow, wow, wow.
We're enjoying it.
yes, we are.
It's already started, has it?
Yeah, we're done one course already.
Isn't that something?
We do like 4 or 5 days in a row, 9 to 5 on Zoom.
Wow.
Yes, I just got my book, Eric.
Mine's not coming till the week of the 18th.
I start my extra fellowship as well next week.
I'm well into mine. I'm busy.
That's amazing. You guys are awesome.
Thank you. So are you guys.
Thank you.
You got to take the opportunities they come, but it's particularly busy on top of everything else right now. So, but you never turn down a good opportunity.
No.
That's right. Yeah. And it's all about the timing.
Yes, it is. Yeah.
You want something done, give it to a nurse leader, right?
That's the truth. So welcome everyone. It's 4:31. I think we'll get started just in the interest of time because we have a fair bit of content to cover. I see there's a couple of participants on already. Hopefully a few more will be trickling in. And so my name is Catherine. I'm a nursing policy analyst with RNAO. I've met, I think, majority of people in this chat, but for those I haven't yet, hello and welcome, and thank you for joining us. We're going to go through some slides here, and I'm going to pass it over to Sally Baird.
Hi, everybody. I as well want to welcome everybody here on the call. We had probably about 11, 12 consistently last month on our call. So hopefully this is going to grow just a little bit more consistently every time we hold one of these sessions. I want to just draw attention to some of the agenda that we're going to be going through. Of course, today we're looking at the recommendations from the task force. So definitely don't want to spend too much time on introductions and rather just get moving on that really interesting topic that's so pertinent to all of us NPs that are looking forward to having even more of a scope of practice moving forward. Just the next slide. Yeah. So that's introduction, sort of. I think the other one.
Sally, sorry to interrupt you. If we could just go around the table, maybe. I think there's only 9 of us here.
Yeah, let's do that. Catherine introduced herself, and I'll just introduce myself as well. So I'm currently one of the co-chairs on the Nurse Practitioner Interest Group, and learning a lot in that role, and it's actually quite exciting for me to be able to be at this level in the RNAO group and get to know kind of the inner workings of RNAO. So I'm wondering if I think everybody sees the same list going in alphabetical order, maybe not, but if the next person can introduce themselves, that'd be great.
I think that's you, Beth.
Oh, hello. So that doesn't work then, Sally, because my name is at the top of the list.
Oh, there you go. That's what I was wondering. Okay, so I'll introduce the person and then please tell me a little bit about yourself. So Beth, go ahead.
Oh, thanks, Sally. So hello to everybody. My name is Beth Sweeney. I was the first NP of the new program, which was started in Ontario in 1995. And I've just taken off with it, love it, full scope. I'm in the family health team that's in both Strathroy and Ailsa Craig, as well. I'm in the youth justice system in Ailsa Craig. So it's fantastic. Just December passed, so a year and a bit. I've been 1 day a week with the RNAO. I'm the nurse practitioner policy consultant. So I'm really enjoying that role. Andrea was our full-time NP and she's had a baby. So thank you so much for Sally really stepping up in the NPIG role. And we're very excited with our new NPIG Facebook group. So everyone on this entire group, I want to make sure that you're all part of our private and nurse practitioner interest group Facebook group. And if you're not, we'll talk about that later, but that's myself, Beth Sweeney, in a nutshell.
Thanks, Beth. Michelle, I see you that you're the next one on my list here.
Hi, everyone. I'm Michelle Acorn. I'm a primary healthcare and adult nurse practitioner, as well as doctor of nurse practitioner. Been with RNAO for years. I've co-chaired many things. I'm actually in the position right now, Provincial Chief Nursing Officer. And I'm back to a student again, doing a postdoc fellowship with Eric and I, actually, international inaugural class. Thank you again,
Congratulations.
Sally, for your leadership, and Beth for all your contributions. I do know how much work it is and the passion, so I greatly appreciate that and happy to help.
Yes. Eric, let's hear something about you.
I'm Eric Staples, and I've been involved as an APN since around 1989 and was the first graduate from the ACNP program at U of T in 1995. Have a Doctor of Nursing Practice degree from Case Western in Cleveland, and that's where Michelle and I are both doing postdoc. And currently, I was involved in the Coupon program from 2000 to 2013-ish, and retired from McMaster and have worked as an independent nursing practice consultant. And I wrote the very first book, which was sort of the Hamrick and Sprouse of Canada, the Canadian Perspectives on Advanced Nursing Practice, which came out in 2016, and the second edition is coming out next year in April or May.
Mm-hmm. And Michelle has it there for anyone who's interested in purchasing.
There we go.
Thank you, Eric. And I hope I say this name right, Asser. Maybe you have it on mute. Yeah, I wonder if I can unmute it for you.
I think he is unmuted there. Sally. Oh, there we go.
Yeah. Nasser, are you there? Perhaps Mike Shy. Maybe we can have Barbara speak. Got a lot of shy people. Perhaps we got some people that have joined but not quite on the screen. Is there anybody else who would be willing to introduce themselves and tell us a little bit about yourself, where you're at?
Hi, I'm Margaret. Can you hear me?
Yes.
And yeah.
So my name is Margaret Tersini. I'm a nurse practitioner since 2015, but have over 20 years experience. I did the primary healthcare certification, but actually I'm working in geriatrics with a geriatrician in his private practice. And so part of my role is clinical trials with dementia, as well as clinic follow-ups. So I'm actually very new to this interest group, so this is my first time attending. So I'm eager to learn a little bit more about what this is about.
Oh, thank you for joining us, Margaret. I do hope that you and the rest of the nurse practitioners will find this venue and the Facebook venue as areas where we can support each other. I think that's the biggest piece, learn from each other and support each other. So thank you for joining us. Anyone else want to introduce themselves?
Hi, good afternoon. I'm Corsita Garaway, and I'm a nurse practitioner. I graduated from the Duville program in 2002. And so I was part of the I worked in acute care for most of my nurse practitioner life. Oncology and palliative being my areas of specialty and love. So currently I'm in independent practice and I'm seeking other opportunities to put my skills to use. I've been part of RNAO throughout the years from when I was from my days of as a nursing student, actually. And, sort of in and out, but just always following the policies and stuff. And I like the work that they do. So it's one of the areas that I've been spending a lot of my time lately. Thank you.
Thank you, Cressida. And I see in the chat group, if some of you don't have that open, we've got some other folks that have actually just let us know who they are. So Jan, thank you, and Sue for letting us know. So please definitely in the consideration of time, please, if you haven't had a chance to speak with us by introducing yourself, please do put a little note in there that we can take note of that as well.
Before you move on, Sally, I did just want to say hi. I'm Irma Jane Baynock, and I am from RNAO. Good to see all of you. I am the acting director now of nursing and health policy, working closely with Catherine and Sally and the NPIG and NPG. So great to see you all and look forward to a great NP Insider webinar.
Thank you, Irma Jean, for speaking up. I thought you were coming on at 5, so it's nice to see you at this time already.
Isn't that exciting? I had a meeting that ended early. Wow.
Oh, thanks for joining us early instead of going for a snack or something.
Oh, right. I could have gotten a Starbucks.
As an aside, Irma Jean was one of my professors at Ryerson.
Oh, yes, I think I've taught everybody. But good to see you, Eric, and Michelle, and all of you, really.
Awesome. Well, thank you so much, Sally. We're going to move on to an executive update. And Sally, I'll let you lead this as well.
Yes. So we just have 4 new members that have just joined the group, and I just want to welcome them here. We've got Janine Harrison, who stepped up to do the social media executive officer role, Patrina for the policy and political action officer, Taylor North for a student liaison position, and Eric Staples as also a student liaison. It's actually really cool to see Eric in a student role when I would look at him as a mentor in the nurse practitioner field, and he's actually doing that role. It's just amazing. So thank you to, yes.
We always move back and forth.
Yes, it's a way of life learning, isn't it?
It is.
Yeah, so thank you so much for coming and joining the team, and we look forward to a smashing year with these opportunities that we're working on right now.
Yes, absolutely. Thanks so much, Sally. So we're going to move on and focus the bulk of this presentation on the Nurse Practitioner Task Force, which has been so aptly called Vision for Tomorrow. And really what it is a group of NPs that represent a variety of sectors and settings in healthcare. And they really came together starting last year. Closer to the summer, the group was actually announced by RNAO CEO Doris Grinspun at the annual general meeting in April 2019. And that really came together as a result of a lot of dialogue at that meeting with regards to the nurse practitioner role and how there were many barriers to their practice and a lot of the hiccups that they were seeing on a day-to-day basis. And really what RNAO wanted to do was bring this group together and find solutions for the role that will not only benefit nurse practitioners, but also the people that they care for. So this here is a picture from our last in-person meeting, which is sad to say, probably one of the last times we'll be meeting together as the task force is nearing completion now. And so that was taken in February. And really just an excellent group. We do have nurse practitioner representatives from long-term care, public health, Indigenous health, primary care, correctional facilities, and policy roles, academia, mental health and addiction, and acute care. So we do feel extremely lucky. We have amazing representation and perspectives from nurse practitioners in all different areas of practice. And the wealth and knowledge, expertise of this group is just outstanding. So every time we have a meeting, it just shines through, absolutely. And it's been such a pleasure. I've only been with this group since beginning of this year, but it really has been a pleasure to work with everyone and to bring some of these recommendations together. So we'll spend some time going through the recommendations after we discuss the NP task force goals. So some of the goals were to address current gaps in access to care for the people of Ontario, to optimize the NP role in an integrated system, and really to reflect the quadruple aim and sustainable developmental goals in terms of optimizing the NP role. So we're going to go through the recommendations at any point. If you'd like to comment, feel free to just speak up. I think all of you have the ability to mute and unmute yourself. So feel free to just speak up if you'd like to comment on any of the recommendations, or also put something in the chat box if you like. There are 8 recommendations in total.
Catherine, before you move on, can I just mention, like, I think you probably highlighted this at the beginning, but we do have some members of the task force here. And
we do.
Again, would suggest, Michelle, if you wanted to add anything or join in, Beth, if you wanted to add anything or join in, and is there, I think that's it, right?
I think
who are
so,
on
yeah.
the task force? Yeah, so we'd be happy to have any comments you might want to make, for sure. And
Yeah.
just acknowledging Beth and Michelle for their consistent work on this task force. We've been really carving out a whole new directions for NPs, and their input is just greatly valued.
Absolutely, yes, feel free. Michelle or Beth, do you have anything to the little preamble that I provided? Anything to add at all?
No, it was very thorough. There has been a participant that said she can't see the full screen. Do you think there's a way that she can pinch it down or move it out?
If she goes to view options and changes that, it may help.
Is that a problem that anyone else is having currently, or no? Okay. So view options might be on the panel.
Is that better, Corsita?
Yeah, okay, awesome. Okay, so we will continue on. And again, yes, stop me at any time if you have any comments to add whatsoever. So for the recommendations, I was saying there are 8 recommendations that we've worked on over the course of many months. And some of these recommendations do have a number of sub-recommendations that are related, and we can for sure discuss those. But just out of the interest of time and really for a high-level review of what these recommendations will be, I've kept it with the overarching because the sub-recommendations do get quite detailed, pardon me. So we'll stick with the overall, and then if we have time, I think we can come back and discuss further some of the additional recommendations that we have. So to start, for our recommendation number 1, we want to see more nurse practitioners in Ontario. So we have increased the supply of nurse practitioners across all sectors and settings. And actions that have come out of this for government are to develop a comprehensive health human resourcing plan, and for government and academic institutions to increase funding and capacity for seats in NP educational programs. So we have recommendation 1 there. Any comments before I move on to number 2? No? Okay. Keeping in mind, these are really high level. Okay, so recommendation 2, we have optimized the utilization of nurse practitioners within current scope. And for that, we will be asking government to scale up some of the models where nurse practitioners are currently practicing, including primary care, as well as into some of the areas where nurse practitioners are not traditionally. And so, for example, that could be human trafficking centers or places where people are receiving care for mental health and addiction. Really into some of those vulnerable populations, we are looking to have nurse practitioners really be optimized in those settings. And I'm just gonna mute all of the lines quickly because I feel there's just a little bit of feedback. Okay. So feel free to unmute yourself if you would like to add anything. But this is our recommendation for optimizing the utilization. Okay, recommendation 3 is in regards to expanding the scope of practice for nurse practitioners. We didn't get too specific into exactly which regulations and scope we would like to see expanded, recognizing that the scope is continuously evolving, and we do currently have some regulatory amendments that have been proposed by the government with regards to MRI, CT, and point of care testing, so we are quite hopeful that those will go through. But in general, we are looking to continue expanding that scope of practice for nurse practitioners, and in order to do that, we will need government and regulatory bodies to make the necessary changes in legislation and regulation in order to respond to the population health needs. As well, OHTs and organizations should be implementing policies and procedures that will allow NPs to work to the full scope of practice in all domains of practice. And so we know sometimes when a nurse practitioner's scope is changed in the legislation and in the regulation, there can still be organizational barriers that prevent them from actually practicing to that full scope. So we would like to make sure that that's addressed at all levels. And as well for RNAO, a key action is to continue the advocacy we have been doing for many years to keep up with that NP scope expansion. Any comments there? No? Okay, for recommendation 4, we have align nurse practitioner curriculum with expanding scope of practice. And this recommendation came after a lot of discussion with nurse practitioners, discussing how some of the clients that they see in the populations that they serve, they really wish that they could have had more of an opportunity to learn more about those groups. And we absolutely think that nurse practitioners should have access to continuing education and professional development. And so this recommendation is in line with that, as well as meeting any current gaps that there might be in some of the curriculum. So we have the academic institutions and CNO to continue with their review of curriculum in order to identify any gaps and areas for revision, as well as for the government to ensure there is funding to enable NPs at PhD and DN or DNP levels to provide faculty support. And so I did have, yes, Eric, please.
The first point here, this is what I'm focusing my whole postdoc on. Wow. And I'm working with CASN, which is the Canadian Association of Schools of Nursing, which are involved in looking at graduate education across the board. So I'm working with them in terms of, we have an agreement about what NP courses should look like, but we know that the NP role is evolving, and certainly COVID showed us that with technology, telemedicine being a big one, and also, you know, do the non-NP courses that students take before or parallel with their NP courses fit the role of the NP going forward. And so that's what I'm looking at in terms of my postdoc. So I'm happy to work on recommendation 4 with RNAO big time.
Oh, that's fabulous, Eric. That's wonderful. And it sounds also very useful in terms of some of the other actions and some of the other parts of the recommendation where we're looking, I don't know how much you've done in this, looking in relation to aligning nurse practitioner curriculum with First Nations to support nurse practitioners in those communities.
Yeah. Really looking as well, you know, the whole social determinants of health and where NPs are working and which groups, and are we preparing NPs to work with these very vulnerable groups. And we keep focusing on health. And we heard in our first class in the postdoc, it's the socioeconomic level of people that really drives health and a lot of the other things that lead that's where the NP should maybe be focusing on.
Mm-hmm. Mm-hmm.
And also further to this recommendation is the reality that within the task force is members of CUPN, and the reality that when a new scope comes out for us as nurse practitioners, the information has to be crammed in. It's not in the program as it stands. They have to put it into a weekend course, and this is has to be acknowledged and changed as well.
I was just going to add as well, further to what Eric and Beth added, is discussions in this recommendation were not just CUPN, but remembering who the other academic players are, not just, this is Ontario, but pan-Canadian as well. For example, U of T is outside of CUPN. Athabasca, we do get also many programs here that increase our health human resources. And we also, I co-chair PNAF, which is the Principal Nursing Advisory Task Force, and we move forward with a vision for nursing where education, regulation, and scope of practice all align from a pan-Canadian harmonized mobility perspective. So even moving forward with the generalist approach for NPs, all of these things need to be considered. So I want to make sure you know, this is important work Eric and RNAO and others are working on, that we want to ensure difference between entry-level competencies and moving novice to expert, right?
Absolutely. Thank you so much, both of you, for sharing. And Eric, I'm sure we'll be in touch with you in terms of recommendation number 4. So we do appreciate that.
Anytime.
Thank you. Okay, so for recommendation 5, we have harmonized upwards nurse practitioners compensation across all sectors and settings. And so this recommendation has come to be because we recognize that there is not necessarily wage parity for nurse practitioners across different sectors and settings. And rather than saying harmonize nurse practitioner compensation, we want to harmonize upwards so that wherever we have the highest level of NP salary, we're ensuring NPs across all of the sectors are able to achieve that same level of compensation. And for actions, we have government to enable NPs to obtain funding for scaled out positions, such as the ones that we just discussed in recommendation number 2. Organizations and OHTs to offer compensation and benefits packages in line with recent salary recommendations, and for RNAO to continue to advocate for equitable compensation and benefits. That's something that we have really been a staunch advocate for in the past in terms of wage parity across sectors, not just for nurse practitioners, but for registered nurses as well. And so we will absolutely continue our advocacy in this area. Any comments on that one before we move to 6? Okay. So for recommendation 6, invest in research to support NP practice and improve health outcomes. So actions are for academic institutions.
Catherine,
Yes.
Dorothy just had a comment she wanted to make. She wanted to go back to number 4. She was having trouble with her mic. I'm sorry.
Mm-hmm.
She was talking about working in addiction services and feeling there's a lack of education and experience in withdrawal management. I think that really connects very well with the comment Eric was making about NPs working with vulnerable populations. And interestingly enough, and Beth will be talking about this a little bit later, we do have case studies that members of our task force were able to share, and they really do reflect a wide range of work being done with vulnerable populations in various settings, whether it's corrections, street care, community health clinics. So there definitely was a great understanding that the curriculum needs to reflect the critical needs of vulnerable populations. So I think you're right on there, Dorsey. Does that help, Dorsey? Oh, it says it's Donna.
Yeah, I think that was Donna.
Oh, Donna, why? Oh, I'm sorry. I've got Dorsey on the mind. Donna, does that help?
Donna mentions that she doesn't mind helping with an education piece on that topic.
That's fabulous. This
Yeah.
is great. And we're keeping note of this.
We are recording, and we'll save the notes afterwards so we can be in contact with anyone that requests us to be.
Oh, and that was Dorsey's last question before she had to leave. Is
Yeah.
if thanks.
No problem. Okay. Okay, great. So are there any further comments on number 4? Okay. I will move back to recommendation 6, I think we were at. So this, as a reminder, was with regards to investing in research to support NP practice and, of course, improve health outcomes. And some action items were for academic institutions to promote NP-led research and ensure there is NP preparedness in order to utilize and conduct research. RNAO to help secure funding for an NP and CNS research chair position, as well as to move forward with the creation and maintenance of an NP CNS related research database. And really this would look at NP effectiveness on clinical outcomes, on cost effectiveness, and some other really pertinent research related to NPs, as well as organizations and OHTs to really encourage and support protected time in order for NPs to actually conduct research, because we've heard time and again that protected time for research is really not that common. And so we absolutely would like to see that part of the role built into the role as much as possible. Yes.
In the new book that's coming out, Perspectives on Advanced Practice, we have a whole chapter that Denise Bryant-Lukosius and Ruth Martin Meisner wrote about the CNS and NP roles separately in all of the research, Canadian research around outcomes, efficiencies, effectiveness, etc. It's a very long chapter. We had to break it out into tables because there's so much along with the writing. So some of this is certainly, I handed over to RNAO in this recommendation because a lot of what they wrote for the book, for that chapter, will be very useful for this recommendation because it really shows the NP and CNS sensitive outcomes that have been studied in our country. And I guess it begs, where are those that we're still asking, where are they? Because they are out there, but we're still asking about outcomes in that. But
absolutely. Thanks so much, Eric. And Michelle, you can correct me if I'm wrong, but I do think you had mentioned actually the name Denise Bryant at one of our recent meetings. And we have it noted down just to ensure that we're capturing the work that she has done in this research database. When we do get there, we've started some preliminary discussions around actually creating the search strategy and starting to capture research, but we don't want to be reinventing the wheel and missing any really relevant research. So we for sure will be connecting with those who have already done this research. And if you have any other suggestions, we're for sure open to those as well.
Thanks, Catherine. I did send you the link as well for the Canadian Advanced Practice research and through that group, but there's a whole link with that. And they're certainly contributed a lot of work, as Eric mentioned.
Amazing.
And I think, as you've both been implying, it's so critical that we take a pause when people keep saying, oh, but we need more research. Oh, but we need to know the impact. Oh, but, and we have it. It's time to use it. And this is where I think a database can really support all of us when we say there is strong evidence, here it is, rather than putting more money into doing more research when we already know the answer.
I just wanted to add as well to that last point where organizations set apart protected time for research. Ironically, I just interviewed for a position this morning at a hospital in northeastern Ontario, and I asked the question whether the job description stated hands-on position, and I felt that the job was sort of suggesting that you don't have any opportunity outside of clinical practice. And so I took advantage of the interview moment and kind of said, is there like that 80-20 possibility, 80% clinical and 20% research, administration, policy development, etc. And they sort of were surprised at my question, but I thought, even if I'm not ever offered this position, maybe they're thinking about this conversation that we had in that interview, but it seemed to be a surprise for them. So, but what was really neat was this is a new NP role for this agency, and I gave them a hand clap. I said, thank you for considering nurse practitioners in your agency and taking that opportunity and adding us to your team.
That's fabulous. Good comment. Thank you. And yeah, take every opportunity, right, to advocate. That's part of recommendation 8, the public education.
Great. And we just have a comment from Donna. That is, each health system likely has an NP advisory council, and I am on the Niagara Health NPAC, and we are working toward arranging for time at the agency level to get research time. So that's awesome. Okay. And has that been received well by others in the organization, or has it not gotten to that level of discussion yet, Donna? Yeah, so since COVID, everything is on hold.
Yeah, no. However, thank you for raising that, Donna, because I think, again, the NP Advisory Council is a target group we can look at for a number of our related actions, and in particular in relation to the public education and some of the other areas we want to focus on.
Absolutely. Thank you for sharing that. So moving on to recommendation 7, we have optimize access and continuity of care by ensuring all insurance benefit carriers and other such payers accept nurse practitioner services analogous to physician counterparts. So Beth, maybe I'll hand it over to you, because this is really Beth's pride and joy for the last little while.
And it's been frustrating because I thought coming with the handle of the RNAO, and we have been legislated for so many years that, what do you mean we're not on the paperwork? So it has been quite interesting to the extent that, in fact, we've had a larger meeting with Doris and meeting with the powers that be at the larger insurance carriers. And surprisingly, even as I've posted in both the NPIG and the private primary healthcare nurse practitioner Facebook group, when I had said that Great West Life was taking an entire year, 2021, and moving all of their policies over to the lingo of only physician to include either physician and nurse practitioner, or change it completely to healthcare provider. Well, they announced that that's not happening anymore. So that was very surprising. And who knows if that will change again, hopefully with more pressure. I mean, that's our standpoint, is to apply more pressure, because it's just it's just not right. And so then we've actually gotten a lot of support from Sun Life to say that they are committed to changing their lingo, their policies. Now, as you know, practicing as NPs, your scripts are going through for the most part, but sometimes it's frustrating when they're not, and it's frustrating if your script is only able to be effective for 3 months or so, and then has to be reviewed by a physician. So that just does not fly when nurse practitioners are often the primary care providers, and even especially when they're MRPs in the nurse practitioner-led clinics and in many organizations across Ontario. So it's just very frustrating when even those insurance companies that say they're committed to us still have on their paperwork the word physician. So it's going to be a process, but I think it's so exciting that the RNAO is 100% committed to having that change, like no ands, ifs, or buts about it. And you know that we're not the only people and organization that are fighting for this. The Nurse Practitioner Council, that's the national NPAC, and even the College of Nurses, right? They've also spoke out. And so it's moving right along, but it never was a done deal like I thought it was going to be. I'd love to hear back from anyone else on this call about that.
Certainly, Beth, I just wanted to add to that the strategy RNAO is really looking at using is to focus on those who are doing this, who are looking at accepting nurse practitioner services, and really rawing those groups and featuring them, finding ways to profile them, so that we move from the situation of a strength, maximizing the strengths, rather than wasting a ton of time on organizations that are not going anywhere. Let's focus on those who are, and then help them bring up their colleagues, because it's a highly competitive business. And if those who are doing this are attracting more clients, then that will help turn the tide. And I think some of the work Beth is doing is absolutely amazing, because given the competitive nature, again, it's a one-by-one discussion. We realize they are not comfortable coming in a room all together and talking about this. So Beth has got work cut out for her, but the more information they have and the more they know the kind of impact we can have by profiling those who do this, I think the faster it will happen.
Mm-hmm. Absolutely. And one thing just to note from the meetings we did have with some of those carriers was it's clearly not only an issue for nurse practitioners where it creates extra work for them, and also as well for the physicians if they have to sign off on a script where they maybe haven't seen the patient. It also is really cumbersome for the client if they are having some of the services they need or prescriptions covered really rejected from their insurance company. It just creates longer time for them to actually access the care they require. And in the end, it creates dissatisfaction with the insurance company. So we do think that over time, with pressure and hopefully with a big campaign coming soon, that will really be highlighting some of those insurance carriers who are moving in the right direction, that we will start to see the changes and get everybody all on the same page. We know it's not just going to benefit nurse practitioners, but obviously clients as well. All right. So moving on, I guess, sorry, for the actions, we are asking insurance companies, of course, to be implementing immediate policy changes in order to recognize those NP prescribers, as well as for government to step in when necessary to change legislation, regulation, and any administrative changes in order to recognize NP prescribers. Okay, so moving on to our last and final recommendation, which is an exciting one and hopefully one that really does elevate the status of the NP. And so it's to engage in public education campaigns to enhance the knowledge, understanding, and full utilization of nurse practitioners. And really what this came from was a lot of discussion how nurse practitioners practicing really feel that there isn't widespread understanding of the NP role in Ontario. There's confusion around what they can and can't do. Sometimes there's hesitancy of patients to see a nurse practitioner compared to a physician. And so we really want to elevate that status of the NP, make them aware of everything that nurse practitioners can do, and really doing that through a public education campaign. So RNIO has committed to really driving this awareness campaign, and we're hoping as much as possible to bring organizations and OHTs on board in order to promote the role of the NP as well. Any comments? We will be asking some questions specifically about this recommendation soon, because this is something we're really going to focus on. But any immediate comments or questions on this recommendation before we move to the case examples? Okay, from Donna, I also see issues at the employer level with recommendation or with requisition, sorry, or BPMH, where it does not have NP for signature only physician. So, and what do you do in those circumstances? Do you have to refer your patients to a physician then, or? Cross out physician and sign with NP. I mean, you have to be resourceful. And
That's what we're doing. And we're sending a message. Absolutely. Good to hear that. I'm so glad to hear that. The only problem is when the patient gets turned down at the patient level, right? So we just hope that doesn't happen. But I know probably like you also, we're telling the patient saying, can you help us out here because this is ridiculous, and I really hope that it doesn't slow your script down, or your coverage down, but can we work on this together? Like, I let my patient know that I'm kind of peeved off that it only says still physician.
Mm-hmm.
Even the bottles that the patient comes home with, it says Dr. So-and-so. And so my name shows up on that. And ironically, there's one pharmacist that sent me a refill request and said, Dear Dr. Berg, and just slashed out the DR and put NP there. So even the pharmacists are joining the NPs in this topic.
Mm-hmm. That's interesting. Thanks for sharing, Sally. Okay, I think it's safe to move on. We're going to, just recognizing we're already at almost 5:20, so I think it's probably in our best interest for Beth to talk quickly about her case example, and then we'll move on just to some more discussion and questions, and then do a quick adjournment for 5:30. So Beth, if you would be kind enough to share your case example, maybe I'll just preface it by saying that throughout the report, we are going to be using case examples to really bring these recommendations to life and make them really quite tangible and easy to understand why we got to where we got to with the recommendations. So the purpose is to illuminate the skill, knowledge, and value add of nurse practitioners working in various areas, including Indigenous health, correctional facilities, mental health, and addiction, and also to examine how NPs were able to adapt and excel in pandemic planning and care delivery during COVID-19, because we have heard time and again how nurse practitioners have just stepped up and really shown through with regards to pandemic planning, but also in many instances where the physician was no longer available, or there was really an absence of physicians during the pandemic. And so we really want to capture that in the report through case examples. So I'll hand it over to Beth, who wrote an excellent case example for us with regards to her role in correctional facilities. You're on mute there.
Thank you.
Yeah.
So in a nutshell, I really just showed in the case example, I mean, I'm talking to my colleagues here who are working in the advanced scope of practice. I just laid out in the case example, the advanced scope of practice that I have in the correctional facility. For example, was my specific case where a 16-year-old, a 14-year-old, 13-year-old my specific population is 13 to 18-year-old females in this particular secure facility that I wrote my case example about. But in the reality of the everyday situation, as you would expect it, is that I'm the first contact with healthcare, possibly for many months, possibly that this youth has been picked up off the street, possibly wearing hardly any clothes at all, and we have to also clothe this youth at the facility. So I'm doing a mandated intake physical from the province, as well doing the expanded scope of practice, so that I'm caring for this youth and covering all lifestyle incidents and health promotion, disease prevention. So I'm able to do the full assessment and also test for STIs and pregnancy and anemia. And it's all about that. And that's the full scope of practice that I laid out very clearly what we do as nurse practitioners. And I may or may not get to see this youth next time I'm in. They could be in just to get sentenced, but they could also be in to serve a sentence. And in that case, I have a lot of time with this youth. But I don't know when I meet this youth the very first time if I'm ever going to see them again. But sometimes these youth are completely under the influence, and that's not the time to do all the care that I need, all the teaching, all the lifestyle. And so it's really advanced practice, and it's a gift that I hold very strong as that. And what I wanted to do in the case study is show that we have this advanced scope of practice, and then with COVID, no docs, no psychiatrists, no social workers, no anything were allowed into the system, only myself. I also became the medical lead for all of this facility, which my case study is specific to the secure facility for girls that are 13 to 18, but my facility has 4 different houses on it and another house in the city of London. And I'm the medical lead. I was on the phone calls every morning with management, and we managed to not have any cases. We developed policies far before you'll see the province's correctional facilities and those living in close communications. We were done it. I mean, it was a lot of work, but it was necessary, and I do believe it was done to the T because of the role of the nurse practitioner. And that's an example for, as you know, the RNAO is working to have a nurse practitioner in all of long-term care facilities, but also it is an example of now I'm reaching out to other correctional facilities and seeing which of them have nurse practitioners and which of them, so far, all the NP-led correctional facilities have no COVID. So isn't that fantastic? And also, the reality is that a lot of the nurse practitioners are gonna try to not have the docs come back because they were sharing, and I don't know where this is going with the province, but they make a huge stipend to come into a correctional facility. And that's a big cost to our healthcare system as well. So, and even that they're retired docs that are going in and charging a big per hour. So that might be out of pocket. Point is, we've got an opportunity here, NPIG and nurse practitioners, and it's all about the patient, and that's what it's all about, and the healthcare system. So that's important to know. Now, also, I'm feeling kind of frustrated because I don't see this youth like ever again, possibly. And we saw this as the role of possibly with an OHT of allowing there to be an expansion of my involvement or any nurse practitioner's involvement in a correctional facility with the youth once they get out, because they could be with the CAS, they could be going back to a parent. I try to connect as much as possible, but I only connect if I have results, like diagnostic results to give to a youth and they're not here with me. That's the only reason that I've gotten their consent to connect with them out of the system. And so I often think about where are these people, and are they really following up, and did they ever do this? And I'm sure, oh no, you know how it goes. So if we had access to these youth through the OHT, that would also be a huge plus for the patient.
Beth, that's so interesting. Thank you so much. One of the striking results I found in looking at all of the cases was this issue of follow-up not necessarily being possible always because of the type of client and the situation. So if, however, our healthcare transformation can address that, I think it would be amazing.
Everybody loves to hear from me and loves to hear the follow-up, but it's hard to do. We don't even often get who the care providers are. And there's so many specialists often involved or have been involved or should be involved. And it's just a real, it's quite the system, the corrections and the I think the nurse practitioner, and if we could connect in our healthcare transformation, wherever that is, it would be the missing link. There is so much money being spent in the correctional system. And I do believe that nurse practitioners would be the missing link to pull that patient load of care together.
Mm-hmm. And if I can just add, I think we noticed that across a lot of our case examples where nurse practitioners were working in vulnerable populations, that there is often a gap in care, and really sadly, a lot of patients end up kind of falling through the cracks where they're missing appointments or they don't have someone that's able to follow up with them. They don't have easy access to service. And so we are trying to highlight the role of nurse practitioners as system navigators and really people who are able to provide that transitional care between sectors and settings, of course. And I think that's the perfect example that you've given just there, Beth. So thank you. Yeah.
Thanks.
Awesome. Okay, so we have just a couple of minutes left. I will quickly just say that we are working on the report. It's going to be going back to task force members for their review in September twice, and then throughout that time frame, in August and September, RNAO will be doing a lot of internal work on the report, but with the final deadline for November 4th to 7th, the report will be released and made publicly available. So we will absolutely be, I'm sure, sending out notifications through our email channels to NPIG members and really across all RNAO platforms. So please do keep an eye out for that. And just in the couple of minutes that we do have left, if I'd just like to open it up for discussion, if there's really any further comments or anything any questions, anything you'd like to add. We were going to talk a little bit if you had any specific ideas for really engaging in a public education campaign. Please feel free to share what's ever on your mind in the final few minutes of the webinar.
Thank you for doing that, Catherine. Great presentation.
Thank you, Cressida.
My question is about insurance and our coverage.
Mm-hmm.
So obviously we need to have coverage for the PLP, which we have for our RNAO members. Is that enough, and is it the same as what NPAO offers or what CNA offer? I always get confused when I'm seeing different information from the different organizations, and people are asking for a certain amount of PLP. So I just want to know what the difference is and whether we generally are protected completely with what we have with RNAO.
And I can start with this and to say that because part of the portfolio when I was presenting to the universities, all 10 of them, that is the inclusion of that part of the information. And our PLP and the RNAO is the superior. It covers everything. The PLP is covered with our membership. And then I also suggest, of course, the LAP for the mere $60, and that's never changed since I was even a student, that price. And it is non-discretionary. And that is huge in comparison to the RNAO coverage that they have with CNPS, because that is discretionary, meaning they're going to look at it and then decide if they're going to cover you and look into your case or not. But for the RNAO, if you're within your scope, and it is going to be covered, and that's the wonderful thing. And there's more than enough coverage with respect to what each employer needs, and even people in independent practice. It's way more than required.
Thank you. That's what I
And
wanted.
actually, to put some figures on that, it's $10 million
Yeah.
coverage for each claim, and then an annual claim ceiling, I guess, of $10 million. And any of the claims we've had haven't even come close to that.
Right.
So it's really seen as Beth said, superior coverage, and we made sure that no NP would be disadvantaged because of the coverage being too low. So rest assured, you've got a good PLP.
Thanks, Cressida.
Yeah, I knew it was good, and I knew the facts around it, but it was just, I started to get confused when I was seeing so many different organizations that we belong to, and everybody has their own. So then I started to second guess my, like, did I do more of something else that I'm not having, you know what I mean?
You're not the only one, Corsita, and
Okay.
I think it also behooves us to be advocates for the RNAO PLP, because
Yeah.
I'm part of the Thames Valley Family Health Team. It's the largest family health team in Ontario. There's 25 of us, and then within each health team, there's sometimes 3 NPs. So when we get together, there's a lot of NPs, and there was even NPs last year, Corsita, that bought both just because
Right.
they didn't know. So
Yeah.
I'm an advocate now, saying,
Yes.
guys, you're wasting your money 100%.
Right. Yeah. Thank you so
RNAO.
much, guys. Thank you.
RNAO did a great presentation on this at the very first NP retreat last year. Probably it should be on the agenda for every retreat when new members come on that, to have this discussion about coverage and that, because it seems to be a question.
Yeah.
And
Good
and now that we're visiting every university as well, Eric, we're going into the integrative practicum portion, and that just started last year. Exactly, the big questions coming up because they're graduating, right?
For sure. Okay, so we're at 5:30. I think our time is up. So unless there's any, burning questions or comments, we are more than happy to address now. Beth's like, stop.
Two hands. I have 2 hands up.
Oh, 2 hands. Yes. Okay, go ahead.
2 hands. Okay, so Donna Daly, don't leave. Sue Adams, don't leave. Barbara Corsita, don't leave, because I kind of took a second to look in the Nurse Practitioner Interest Group Facebook group, and you're not in it. So I just want to turn this around. I'm not very techie, but this is the Nurse Practitioner Interest Group Facebook. Looks like this. Can you see that?
We can, yeah.
Okay.
RNAO NPIG.
Yeah, and it's and I even looked back in my email and saw that specifically it was April 13th. If you want to write this down, please. April 13th, 2020, the RNAO sent an email to you to say, so it's titled NPIG Private Facebook Group. That's the name of the email that was sent to you from the RNAO April 13th. And it just shows about what we're about, and it has the little link to join, and there's 4 questions that you answer just to be part of the private NPIG Facebook group. So this is huge. We want this to grow and grow and grow.
So can I just say something with that? I believe I did get some communication along that line, and somehow I ended up in the long-term care primary healthcare group and not NPIG.
Oh, well, just go back to that email.
Yeah. Okay.
And if you have any questions, again,
right.
Beth Sweeney and Facebook, just ask me. No problem.
Okay. All right.
Oh, good. Oh, thanks for raising that. Okay. Yeah, I think we're ready to move on. I was just, one comment I'll make is that, Eric, you already linked our recommendations to the social determinants of health, which is one of the goals. So there you go. Okay, Catherine, take it away.
Thanks, Imogene. I will just pass it over to Sally for discussion of our next webinars and then adjournment.
Yeah, so the next time we meet again in this venue is September 3rd at 4:30. So love to have all of you rejoin and see if some of your colleagues want to join us as well. Since moving forward, there's free membership on the NPIG. So we'd love to see a lot more people next time. So pass on the good news about joining us. And we'll be talking about the mentorship program, which we want to re-engage and build upon. And I just thought maybe talking about the LAP and PLP is one other idea that we can add to our insiders sessions as well.
That's great. And just so you're all clear, and maybe I missed a comment you were saying, but as you know, RNAO has the membership blitz. And so for all RNAO members who are rejoining, they will have free membership in the NPIG for the remaining 3 months, right? That's what you were meaning. Yeah. So it will boost our membership and really, I think, help everyone to get to know the possibilities here.
And I think it's great that the RNAO is offering anybody to be an RNAO member for only $50 for the last 3 months as well. So I think it's great that RNAO is so generous. $50 for anybody. And I'm talking about that to my other NP colleagues who are NPAO members. And I'm like, come on over to RNAO for only $50. And they're, wow, that PLP is really worth it. So they're doing that. But then now, as of today, or yesterday, pardon me, with the RNAO also being so generous to give any NP that's an RNAO member free membership into the NPIG for the last 3 months, that's awesome, because it's usually $25, as you know, to join.
Great. Okay, Catherine,
Yes.
or Sally, is that our end? Aha.
Yes,
That's
thank you everyone for joining us, and we'll meet again.
Yeah,
Thank
and
you
we
so
look
much, everyone.
forward to more of you at the next webinar and to great things coming from NPIG with the new executive. Bye.
Yeah, absolutely. Bye, everyone. Thanks so much for joining.